Apparently we weren't on, and we have to start again. This is the meeting
This
of
is the
top
meeting
retractive
of top
orthodontics, and it
retractive
is being held
orthodontics,
here in
and it
England.
is being
Um,
held here in England.
but previously, there was a
But
production
previously, there was a production.
for 20 minutes about orthotropics, or her general belief that retraction is not a good idea. We will then, she will be followed by India, who is a general dentist with a lot of
For 20
orthodontic
minutes
experience
about
in
orthotropics, or her general belief
Lithuania,
that
and
retraction is
will
not
be
a good idea.
followed by
We will then, she will be followed by India
an
in
experienced orthodontist who is practicing in Poland. We will then shift again to South Africa, where we have another experienced dentist who does a lot of orthodontics, practicing in, I can never remember, Georgetown, I think it is. No, what is it? Right, okay. Yes, and he will then be speaking from there. Then we will move to England, where Granville will give us a talk on from Southampton. He is sitting there with his wife Catherine, who is also a general dentist with a lot of orthodontic experience. Granville himself has been doing orthodontics originally in Jersey it was, and then he moved to Southampton a few years ago. Finally, I will do a short presentation, and we will then have a general discussion. But between each presentation, we will ask for questions from all around the world for anyone who wishes to participate. So I think we are now ready to pass on to Ella Bianca if she would like to open with her subject.
Hello, everyone. I'm Dr. Ella Bonica. I'm an orthodontist, and I will talk about premolars extraction in orthodontics affecting health. What are the old schools teaching? They said that in patients with significantly crowded arch or bimaxillary protrusive dentition, one avenue of orthodontic treatment may include premolar extraction. Bimaxillary proclination of the incisor would necessitate a reduction in the proclination of the anterior teeth. Treatment for this malocclusion can include the extraction of 4 first premolar and retraction of the maxillary and mandibulary anterior teeth. And what are the findings? Premolar extraction and incisor retraction did decrease certain dimension within the upper airway. The extraction of all 4 second premolar decreased anterior-posterior incisor proclination and protrusion, and the pharyngeal distance between base of the tongue and posterior nasal spine. Summarizing, pharyngeal airway size became narrowed after the treatment. Extraction reduced bone volume, creating endognathia and therefore affect ventilation. What matters and which takes priority is skeletal class, the dental, the relation of craniomandibular. And if we extract premolars in a skeletal class 2 to find a dental class 1, we can worsen the patient's posture because we are not treating the root of the problem, which was the skeletal class 2 that caused a previously compensatory posture. The teeth, in fact, stabilize the box, which is the most musculoskeletal reference point. So, first the box, then the teeth. This is a concept developed by Dr. Michel Clausat from France. The effects of extraction on airway dimension. The middle of and inferior airway size were reduced in the group treated with extraction and maximum anchorage. Also, a significant decrease of pharyngeal airway posterior to the tip of soft palate and tongue after retraction of anterior. Extraction of 4 premolar in bimaxillary protrusive patients affects velopharyngeal, glossopharyngeal, hypopharyngeal, and hyoid position, and all of them became narrow after following orthodontic therapy with extraction. During mandibular setback, a change in the position of the hyoid bone to a more posterior inferior position was reported and found. This will result in narrowing of the hypopharyngeal airway dimension and displacement of the tongue to the same direction. The posterior displaced tongue, in turn, narrow the retrolingual spaces and decrease the posterior airway dimension. Post-extraction tongue position directly influence the hyoid. Anatomical dependence of the hyoid with the hyogloss muscle. Also, the hyoid bone moved both posteriorly and inferiorly, as we said before. And maximum retraction of the anterior teeth did influence the pharyngeal airway posterior to the level of soft palate, uvula, and tongue in adults. The other findings prove direct correlation of tongue to oropharynx and hypopharynx. It is well documented the fact that significant changes in dentofacial parameters are expected during extraction orthodontic treatment, which change soft tissue profile and incisor angulation. These changes are likely to influence tongue position and pharyngeal airway. The nasopharynx and hypopharynx are not easy to deform because of supportive bone and cartilage, while the veropharynx and glossopharynx is made up of the soft palate and tongue, which were easily affected by the change in the surrounding tissue. Retraction of incisor after extraction decreased the oral space tongue pressing on the soft palate, leading to the decrease in the size of the upper airway. During retraction of anterior teeth, pharyngeal airway reduced at the soft tissue level, tongue and soft palate, and they are highly correlated with incisor movement. The pharyngeal airway in mandibular setback is reduced immediately, while during retraction of incisor, it is reduced over a period of time. We have to consider the impact of orthodontic extraction on tongue space. Tongue posture and oral space are key variables to be considered for fixed orthodontic treatment with bicuspid extraction. Aesthetics should never be achieved for patients undergoing orthodontic treatment at the expense of diminishing capacity of the upper airway. A case of ASA may worsen following bicuspid extraction. There is a need to foresee this type of patient, and treatment plan should be modified depending on the risk-benefit ratio for orthodontic extraction. The changes occur mainly in the sagittal direction. This implies that there was a reduction of anterior boundary of the oral cavity and its contents, and mainly tongue has to shift posteriorly. The tongue adaptation is likely to reduce the velopharyngeal and glossopharyngeal airway, and this explains the relation of movement of anterior teeth and reduction of pharyngeal airway at the level of soft palate and tongue in adults. This is why there is a significant relationship between movement of lower incisor and reduction in velopharynx and glossopharynx. Changing in the lower incisor positioning may affect the position of hyoid bone. Summarize of the problems in extraction orthodontic treatment. The pharyngeal airway dimension reduced, especially at 2 levels, velopharynx and glossopharynx. The hyoid bone tends to move in posterior direction. breathing dysfunction leading to SDB and OSA, infertility and erectile dysfunction in some cases, disorder of cranial-cervical-mandibular system affecting stomatognatic system and human posture, bruxism, TND, facial pain, migraine, eye pain, dental damage, neck and shoulder pain, or all other problems. Also vision and ENT problems, problems with speech and appearance, of course aesthetic, because changing in the face, profile, concave, retrognathia, and flattering the face usually appear after extraction treatment. A long face with increased vertical height, affecting the eye support, dark circle under the eyes, gummy smile, apical root resorption, and bone loss, reducing the tongue space resulting in scalloping, periodontal problems, anterior or lateral open bite, posterior and low tongue position, and chewing and digestive problem, of course. So the main problem, as you said, is, as you show already, and I try to summarize this, is that the reducing the space in the mouth is affecting the breathing and can lead to OSA in patient. And because we are the gatekeepers of the airway, we have to be very careful with the treatment that we can provide for the patient. Thank you very much, and I'm waiting for your question. And I also can say to you that previously, when I start my orthodontics career, let's say, I was trained in a tweed technique. So I was very proud to be able to travel in US and to do the tweed course in Tweed Foundation in Arizona. So I think we have a question anyway. I'll finish my idea. And we spent 2 weeks bending wire, treating extraction typodont cases. So this is what I learned in the beginning. So I thought that it's normal. But after a while, when I discovered that what I am doing and what they are teaching us is not right, I changed completely my philosophy, let's say. And lucky me, because I've met Professor Mew. So.
Sure.
Would anyone else, there's a question on the screen here. Who would like to start by offering an answer to this question about symmetry?
I'm happy to say something.
Yeah, say something quickly.
It's very important to know how old you are. If you are under 20, there is quite a good chance that you can correct a degree of asymmetry. Most children are born with slight asymmetry. Some children are born with a lot of asymmetry. To a large extent, it depends on the passage down the tube, the birth canal. And if you are able to maintain good posture, by that I mean simply keeping your mouth closed, but with your tongue and your palate, many of these asymmetries will improve on their own, doing nothing else. If it is very severe, you might need either treatment or possibly surgery. But I'm sure other members of the panel would have a comment on that too. Who else?
So is it possible that you're chewing mostly in one side? And also, is it possible that you can have a whole body symmetry? You can check the posture. You need to check the TMG TMG, and also you need to check the cervical spine and whole skeletal posture.
Okay.
And if you improve the whole body posture, also will help you to reduce the facial asymmetry, along with the Professor Mew advises.
We have another question about deviated septum. Can retraction make this worse?
Who would like to answer that?
Usually the deviated septum is already established before in many cases, because most patients during these days are having breathing problems and an incorrect developing of the maxilla. So usually we can avoid the septum deviation if you start early, the treatment before 6 years old. But after that, with extraction, of course, it can become worse in time.
Could I say a word, perhaps? I think you can liken the upper jaw to a cardboard box. There are lots of separate bones, many of them quite thin and delicate. If you push from in front of a cardboard box, gradually it will crumple. And when it crumples, the various linear planes will distort in different directions. And the septum, which should be straight, if you push on it from in front, it will crumple and go to one side or the other. And that is usually what causes a deviated septum. And of course, retractive orthodontics is just that. They pull back the upper front teeth because they stick out, and that tends not just to move the teeth back, but to move the whole of the upper jaw, including the bones inside the maxilla. And of course, if you push on them, they tend to crumple or kink in various different directions. Who else would like? Dominique, what is your opinion on this?
John, yes, I agree. The retractive orthodontics can deviate septum. So for me, it's now it's obvious, but it wasn't through last 20, maybe 15 years when I was a true retractive orthodontist. I got like Ella. So thank you, John. Now this answer is clear.
Okay.
Okay, Bill, but it is the second presentation. The first one is with the crush scars. So.
You're sharing.
Could you show the previous presentation?
You're sharing from your computer.
Okay.
And until you prepare the presentation, there was a question about early extraction syndrome, and I would like to answer this question. If on primary extraction, sorry, the echo it's reducing the thumb space, and it's leading to more vertical growth, which will affect the septum and will increase the septum deviation, will create, in fact, because a vertical growth, it also means that we'll have narrow arches, and narrow arches will start to elevate the airways, anterior airways, so the septum will become narrow. Okay. So we have to be careful with the integrity of the primary teeth don't extract primary teeth. So we need to expand, not to compress the jaw.
Okay.
Dominique should be next.
Yeah, but he's got the wrong slide deck up.
Oh, well, you could go to Indra. She could, or Dominique could talk, whatever, whichever.
Okay. Indra, should we move to your slides next?
Okay. Good afternoon, everybody. I am Indra Mustinena. I'm a dentist. I live and work in Lithuania, and my today's topic is about a gummy smile because I had it myself and I hated it. So here I am with a big gummy smile. I think that the best reference point for showing how bad my gummy smile was is just everyday life pictures. Here you can see how the teeth are retracted. This happened after classic orthodontics, after when I asked an orthodontist to close my gaps. And you can see here how gaps disappeared. The teeth itself looked good, but the whole arches are deep in the face under the shadow of the nose, and I didn't like that a lot. Here you can see the gums even sparkling. The half of the smile is only gums showing. I hated it. I have hundreds of pictures like this. You can see that lateral incisors can't even be seen. I have a picture where I smile only with my gums. Here is one more and one more. And everybody told me that it's just a part of me and that's how I should look like, but I knew that something is wrong, but I couldn't figure out what. There's one more picture and you can clearly see how the incisors are retroplined. I even learned how to look better in pictures. It's just tilt your head back a little bit and the light catches your teeth better, but still the gummy smile was there. Here are my models. The bite is moderate, quite normal and stable, but I had 4 millimeters of the bite, and I had +1 in one side, but +2 in another side. And here, even on the models, you can see that whole frontal segment had swung down severely. And I always was seeking for options. What should I do with this? And the most popular option was Botox. But who wants Botox in their bodies? Then the orthodontic surgery, or to cut the muscle, which pushes your lip up. So I was afraid to do these things. I thought that I would end up looking weird after that. And the last thing is gingivectomy plus ostectomy plus shorter crowns. So this is very, very harsh thing. You end up having not your own teeth, but artificial ones, and the crown and root ratio is damaged, and this is not good. So I lived with gummy smile until I met John. I learned a lot from John New, from Mike New, from Simon Wong, and even in this picture you can see that my gummy smile was in progress already here. I've come a long way through. I redid all the previous orthodontist made for me. I protruded my whole premaxilla and incisors forward. You can see from this picture that the only bite between upper and lower teeth is on the first premolar. I had only one contact here, and I had a open bite, huge gaps here, and a big overjet, and that was not looking good. But a gummy smile started to disappear very soon after studying this. Here I am in further progress with my son, who is wearing bioblocks. Here we both are wearing bioblocks, and you can see the gummy smile is less and less. Just the overjet is big here because I didn't advance mandible at this point yet. And here is a comparison of before and after. You can clearly see how the incisors were reclined previously. I look as a different person, and I feel much better now. These are my recent models. The bite is quite good. I solved the debite problem. There's quite a big mess here in the molar region. There are gaps, but I'm going to close them. And you can see that frontal teeth are reclined in more correct places. So the comparison of the old model and the new one, you can see how far I moved the whole frontal area. It's about the difference between new and old one is about 6.1 millimeters. This means I didn't only tilt the teeth, I moved them bodily. And I lessened my overbite from 4 millimeters to 1.5 and expanded maxilla a little bit. So here's my new smile with gaps in the molar region, but they're still in progress, and I still can show a lot of gingiva well when smiling strongly. But in general, I feel like a new person. I'm over the moon with this, and look how smile is now the smile is normal. It looks good. I can see myself in the pictures, and if we compare pictures before and after, so it's a huge difference, And I would like to share why I love orthodontics so much, because there is a small magic happens with every patient. Like this one, if you expand at correct rate, the maxilla is brought forward, and the time difference between those two pictures are only 2 months. This girl didn't even get her posture corrected, but she looks much, much better. You can advance the mandible forward. This patient was so happy. He said he looks 10 years younger and more masculine. And at first I thought it's a rocket science to move the mandible forward, but in reality, you just have to have a good basis of how to do it technically. And once you learn it, so it's no problem. It's easy. You can get rid of gummy smile. This is a little patient, and you can see clearly how all the frontal area swung down here. And again, this picture is about 2 or 3 months later. This is a small time difference and a big difference for the smile. You can expand maxilla even for adults. I've learned a lot. I've learned osteopathy, and I know that sutures don't, they are flexible even in adult age. This patient was 35 when we expanded her in 11 plus millimeters. So nothing is impossible, and you should just give it a try. You can switch growth direction from vertical to horizontal. Picture A is what we aim for, and there are a lot of patients, the majority of patients who are going to have B or C profiles. So the orthodontics just turns the growth direction. It's for sure. You can avoid extractions. Look at these canines. They are somewhere in between. One of them is in between the central and lateral incisor. It's impossible for them to wrap in their correct places. But with orthotropics, they did. The small magic happens everywhere. And with classic orthodontics, you almost cannot predict where exactly your dental arches are going to be. You get the good arches, a nice alignment, teeth look good in the model or in the picture of the teeth only, but you cannot regulate where they should be. Generally, they should be there, and you get them there. So my message for dentists is please be sincere about what you do and what you have done. Take a good before and after pictures of not only teeth but the face too. And you don't need any fancy software or hardware to measure what's going on. Your eye is sharp enough to catch a difference of 1.5 degrees. So just look and see and think about what you discover. Really handy tool is a new indicator line. I would advise everybody to look for the free PDF of John's chapter, Reading the Face. It's from the John News book, The Cause and Cure of Malocclusion. You can Google it. It's you just have to enter John New, Cause and Cure of Malocclusion, PDF, and you can read the whole chapter. It's really life-changing, and there is a table who teaches to measure the indicator line, and you should teach all the pediatric dentists to measure the indicator line, because it gives you a really good imagination what's going on with your maxilla. And love your patients. Treat them as if they were your own children. Love what you do and be the best. Thank you. Time for questions. Is it possible to correct an error? Yes, it is. And it's not a canine. It depends on how old are you. Teenager. Well, I hate giving consultations when I don't see the patient, but generally you can expand the palate, and in most cases, canines are impacted because there is a lack of space, and when you expand, so canines find their path and usually erupt in their correct places.
Anyone else have a point of view?
Yes, the advantage of orthotropic is that we can expand, of course, more than 10, 12 millimeter, but also we can lengthen the arch. So usually when it's the lack of space for canine, we need both transversal and sagittal, like in wisdom teeth. So this is the advantage of BioBlock appliance.
Yes, I agree. Anyone else? Dietmar, would you like to say something?
Dietmar, you need to come off mute.
Can you hear me? I've unmuted myself. Yes, John, I agree entirely with you and Ella. I generally start off when I'm working, I start off with the sagittal development first, just to unlock the premaxilla, and then I do the transverse development. But I must admit, in the years that I've been doing this, one of the biggest challenges is those canines, those upper canines. And timing there is, I found, critically important, but there's no question about it. In my presentation, I'll be showing one or two cases where I've done so, not using BioBlock, but other appliances, because that's where I started off 15 years ago.
Granville, would you like to say a word on impacted? Well, I thought there's questions. So, is there anyone else who would like to say something?
Maybe me. There are always versus wearing bioblocks. So I believe we had a discussion with you, John, and we thought that in slight cases, in not severe cases, mewing is enough. But if the case is severe, so mewing can help, but not as much as you could do with bioblocks.
Okay, I'm ready. Okay, good afternoon. I'm Dr. Dominique from Poland. Thank you for welcoming me. I have been practicing orthodontics for the past 22 years, so I'm a true retractive orthodontist with the legal license to spoil. However, now I'm trying to be more protractive. I first met John in 2013, and this meeting turned my view orthodontics upside down, and I have been continuing my adventure with orthotropics ever since. So now I'm trying to be more protractive. I want to show you 3 patients who visited me for consultation. The first one came to me a few months ago. He's 12 and a half years old. You can see his measurement above. So he has very narrow arches. Intermolar width is 32 millimeters with a big overjet 9 millimeter and complete overbite 6 millimeter. With elongated face, so his face looks like an adenoid face. Here you can see his arches. So this is class 2 division 1. Even on the cephalometric picture, he still has open lips. But his rest position is the position with the tongue between the teeth. This could explain why his cusps are without any trace of wear. The lateral teeth are secured by the tongue, and why his front teeth are worn and crushed, because the front teeth are in almost constant contact. So you might think that this is atypical for bud growth, but not only bud growth damaged his face. There is probably another potential factor which destroyed his face. It is orthodontic treatment. The patient was under orthodontic supervision for the last 3 years, and when the mother told me that, I asked her about the technique which was used. So on the next appointment, she brought his son's last brace, which he still uses. So now my orthotropic mind sees a terrible contraption. It looks like the prison for the tongue. We know that the improper position of his tongue destroyed his face and occlusion. Sadly, the brace continues probably the damaging process. So the brace is keeping the mouth open. The patient couldn't wear the brace at night. He wear this brace only during the day, because the brace suffocated him. So the term suffocates used by the boy to describe his experience it confirms my suspicion that this contraption restricted his airways. I asked the patient to put the brace in his mouth, and now you can see how the appliance changes his posture, how it elongates his face. I asked him to seal his lips, and you can see what a big effort it is for him and how the mentalis muscle is engaged. Now you can see what a difficult task it was for him to wear this kind of brace. I think that stage 3, the BioBlock 3, is a much more comfortable than this one. The sad conclusion is that the patient lost his best years for the proper treatment. And this is next patient, 18 years old woman. From her early childhood, she was treated by different orthodontists and which used plenty of different braces. So you can see how her growth direction is damaged. She's like the previous patient, but 7 years later, there is a still problem with impacted canine, narrow arches, deep bite, and 8 mm overjet. It's hard to understand why so many doctors in such long treatment would resolve this problem. I asked about her last brace, and on the next appointment she showed me his twin block, another contraption. Now she's wearing this at night, and you can see how the brace increases her vertical dimension. The brace changes her tongue posture. The brace changes her tongue position, which is in even worse position when she's wearing the brace. The brace damages the face additionally. So on the right picture you can see her face with the brace, and this is the comparison with the brace and without the brace, how the vertical dimension increases. And the last case, 30 years old woman, you can see how the growth of her face finished. This is a typical face on our streets, especially in Poland, so this is the class 2, division 2. But what is more interesting is the fact that she had 4 premolars removed on the orthodontist's recommendation at the age of 12, and she never continued the treatment. So her face and occlusion grew without any further medical intervention, in spite of a lot of additional space after extraction, and after many years her incisors are crowded. You can see her gum recession and increased curve of speed and compressed arches. So it wasn't a solution to extract the teeth. So now I want to lighten the mood and end on a happy note. This is my patient. I currently treating this guy. Class 3. I use BioBlocks according to John's instructions, and today she looks like that. So she's now in training phase with BioBlock 3, with stage 3. So I opened her bite and widen arches. You can see the difference between treatment and today. So I'm very happy that I can take part in this kind of therapy. So thank you for your time and interest.
Just one question.
I'm happy to answer that. I'll continue. It's quite common for orthodontics, after they have pulled back the front teeth, to put the wire down behind them to hold them in position. This is okay because it stops the teeth going crooked, but it can have side effects and can cause damage in the long term. This patient is wondering whether she should have it removed. But the risk, of course, if you remove the wire, that the teeth may go crooked again. However, she is asking if she is mewing, will the teeth stay straight after the wires have been removed? And in my opinion, they will if she keeps her posture correct. In other words, her tongue and her palate with her lips touching and her teeth in or near contact. If she does that, the teeth will stay straight, but that is much more difficult than you might imagine. So my caution would be, don't remove the wires unless you are very sure that your posture is correct.
Any other answers for that question? Or should we get another one?
Yes, it's also important to know if he had extraction before or not, because it's influenced a lot. And if the patient had extraction previously and he removed the fixed retainer in the first 1 or 2 years after, she will have a relapse. But it's important to know the case, so we cannot answer exactly. Just and it's not.
I agree with you. Another question.
Yeah. Read out the question.
Well, I have been extracted with 4 premolars at the age of 17 during orthodontic treatment. I have neck pains and migraines since then, but I just linked to the 2 events and I wonder if they are connected. In my opinion, I would say yes, they are very likely to be interlinked, but let me leave it to one of the other panelists to say what they think about the adverse consequences of 4 extractions, presumably premolar, and it sounds as though she then had her wisdom teeth extracted as well. Who would like to speak?
Me. So it's absolutely a relation between the 2 events, extraction of 4 premolars, even 2, and absolutely 4, it's affecting and it's creating the migraine and the headaches, because the teeth are like a postural sensor or capture. So, and it's extracting the teeth, it's decreasing the space in the mouth, decreasing the jaw, and it's affecting the trigeminal nerve. So it's affecting the posture, it's affecting the cervical vertebra, and it's creating a lot of problem, not only headaches and not only migraine, a lot of problem. It will create TMG, it will create postural problem also, even speech problems and many more, many other neurological problems too.
Any other answers?
Hello? Yep. Hello. Oh, hello. Oh, I can't see anybody.
Yes.
Hello. Just referring. I can't actually. Sorry, I'll come in a bit more. Sorry. Hello. I can't see
you.
Hello. Just referring. Hello to everybody. To Granville's book, the "Is Your Bite Quite Right?" Here.
Yeah.
Further back, right. Okay. On page 58, he talks about this impact that just having even 4 teeth at the back taken out can have quite a big impact by although the forward movement from the back of the teeth can be quite small, it can lead to a decrease in height, putting extra force onto the TMJs. And also often where the premolars have been removed, the front teeth have become flatter in their angle, and that can drive the mandible back and up and possibly lead to dislocation of the TMJs. And in both our experiences, the body strongly dislikes having the lower jaw pushed back and up, and the patient usually develops a forward head posture in response to this.
Okay.
Fully agreed there. Absolutely fully. So,
Yes.
Okay. Dijmar, over to you.
right. Can you see my screen, by the way?
Yes.
Can you? Okay.
Yes, we can.
Because I've been panicking on this side because I can't see it. Can you still see it?
Yep. If you press,
Yes, we can.
your slide.
Okay, just hang 10. It's just I don't seem to see it on my side. I just
You
don't
just
seem to
progress
be
your
able.
slides.
Beg yours?
Move to the
There
next
we-
slide.
Next slide.
Yeah. Yes,
Try
I'm trying. My screen has gone blank. That's the issue. Let's see. Okay, I'm going to. Can you see? Oh my goodness gracious! Let
Should
me
we
just
ask Randall to speak for the moment while we get that right?
there I am. That's fine. I can actually see. I'm just going to share with you.
Yep.
Can you see my slides now?
No.
Not yet.
I'll go first if you want.
Okay.
I think you better, because I better get this sorted out. I seem to have an issue.
Randall,
Okay.
are you ready to say a few words?
Yes, absolutely. My practice has taken a very large interest in people with head, neck, back pain and TMJ problems. And so I went off and studied as a cranial sacral therapist, and I learned cranial osteopathy. And I also went back to the Royal College of Surgeons and did all my neuroanatomy and cranial anatomy again. And I have a thing called a Beauchene skull here. And this is the oxbird, and you can see the hole is for the spinal cord. And the most important joint lies in just behind the maxilla, and that is what they call the sphenoid, the spheno-basilar, which is the oxbird, synchondrosis. Now this joint is the cranial base, and any influence which is negative on that, like impaction or twisting or torsion, can lead to problems down below very quickly. And so you may have a knee problem and you go off to your doctor and say, I'm having knee pain. And he says, oh, I'll send you to the orthopedic specialist at the hospital. And he will take an MRI or an X-ray, and then you have work done on your knee, maybe some surgery. When the whole thing can be coming from here. And people need to realize that, because my patients, for years now, I had to learn all this. And I found the most bizarre connections. We're like a slinky. We're like a marionette, a puppet. were joined up with strings and hinges. And if you tweak one part, something is going to happen somewhere. And in front of the sphenoid here, this one, you can see the maxilla joints at the pterygoid plates. And the worst thing I see is when people have used extraoral traction with wishbones, and they've often had bands and tubes on the sixes, and they wear an elastic round the neck or round the head. And I used to use this myself in the 70s because I didn't know any better. And that was the teaching of the day. And the whole idea was to stop the maxilla from growing, which is scurrilous now when we know so much better. But the wishbones would not just drive the maxilla back, it would twist it. And the number of people I've seen with rotating maxillas and rotated spinobasal, twisted cranial base. And of course, the dual tube, which aligns, it lines the cavity of the cranium and protects the brain, but it also goes into a tube and protects the spinal cord and inserts in your tailbone at S1, S2. The dura is, as it is described as the dura mater, which is tough mother, and believe you me, it is. If you twist it, and I've seen this on a cadaver, if you twist it one end, it will respond the other as well as in the intermediate parts. So it's not surprising that people get backache, foot, knee, and hip problems from a mandible and a maxilla, which have been put out of shape and impacted into the sphenoid. It's about as damaging as you could ever do. And I, in my practice of recent years, certainly the last 40 out of my 50 in practice, have been doing the opposite. But I still see some horrendous things taught. And unfortunately, this hasn't gone away. And I know you guys with your mirroring, I take my hat off to you because you're in the right direction totally. You're trying to improve the face physiologically and through the muscles. And I think that is totally commendable. In fact, John, at the end of my book, I put an accolade to you because I feel what you've done and what you're doing, Michael, as well, is very brilliant. So I hope that gives you some idea of the connections. Of course, there are many connections. And it isn't always a bite problem, but it is a lot of the time. The other thing you need to know, everybody who listens, the TMJs are sometimes just glossed over. The temporomandibular joint is an extremely important joint. And if it gets dislocated, you can live with it, but if the disc, the articular disc between the two bones is out of place, you're always going to have excessive muscle activity. And that will impinge on your cranial system. And that a person asked about migraines and headaches. I'd be surprised if they didn't get migraines and headaches, because you lose a bit of the vertical dimension with the extractions. And the whole cranium shifts, the muscles go tight, and basically headaches come from the cervical plexus in a big way. So the muscles of the neck are trying to compensate for the balls up that's been done here. And of course, if they're in spasm, then you're going to get pain. You're also going to get a serious impingement on blood flow because the supply of blood to the head through the atlas, through the basilar artery, can be affected very seriously. I don't think anybody really knows what they're playing with when they do these things. They wouldn't do them. That's about it. I could say more. I think it's enough. Can't hear you.
Right, I
We
think,
have a few questions now.
right, and then we'll, right,
Any questions?
have we got none in on, here from?
I used to
I used to have bad migraine headaches when I had crowded teeth, sharp teeth, when I was younger. If I could travel back in time and tell my young self to mute, that is not really a question. But there are so many older people who regret that they had orthodontic treatment when they were young, which frankly may have straightened their teeth, but did them themselves a lot of harm. And that is what this campaign is. We do need to try and stop orthodontists retracting the front teeth because they stick out. That's not the problem. And here's another question. Shall I read it out?
Yeah, read it out.
Yeah.
I am about to get my braces off and may be given retainers by my dentist. I have straight teeth, but my lower mandible is somewhat retracted and angled downward. Is there anything I should do? Who would like to answer that question? One of you must do. Yes, Ella. Could we, she's mute. You're muted.
Ella's muted herself.
I think it's good to start orthotropic treatment now to advance the mandible.
Yes, I think you're right, but I don't know that the patient will necessarily feel so.
It's depending on the age of the patient. If it's a child, he can continue with orthotropics and exercises. Yeah. If it's an adult, and it's depending of the amount of overjet, he may consider other procedure. I don't know.
Yes.
It's different in child and adult cases.
Yes. I'm sorry. She says her mandible is back, and I think that means she has been damaged.
Maybe it's an adult. Yeah. Yeah, maybe it's an adult. Yeah.
But I would like one of the others to put in a point of view. You must have one. No, I don't want to call you by individual name, but one of you, yes, Cranial.
I think it would be of great benefit to maybe go and see somebody who does orthotropics and just get an opinion so you can kind of balance your ideas. Because if you just take the braces off, or have the braces off, or have the retainers, and you could see how you go, we can adapt to inside. But if your jaw is back, the body really does not like that because it impinges on the airway and the head comes forward. It has to be able to function. So I would go, maybe if I had enough of your braces, I know what it's like to have braces on, get them off, have your retainers fitted, but then maybe go and get an opinion on how that person who does orthotropic work and see what they think. Because it's your wellness, your health. And if your jaw is back, you're probably going to become a snorer and could lead to sleep apnea.
Any other responses to that?
I'd like to complete the question, the answer. In fact, sometimes the mandible it's in a backward position because sometimes with the classical orthodontics we are not able to expand properly the upper arch. So the upper arch it has to be bigger than the lower arch. So if it's not well, the expansion is not enough. It's impossible for the mandible to go forward. And also is depending on the anterior upper teeth position and axis. And what I would recommend along with orthotropics, I recommend a body work. Maybe visit an osteopath and do some specific exercise to reshape all the body posture, the spine and the cervical, and to check the TMG and the tongue position also. It's very important. And doing mewing, of course.
Yes. Well, I totally support you, Ella. I think that once you've had orthodontic treatment, with it is likely to be retractive. Almost all orthodontic treatment is, and the only way to cure that is by taking the jaws forward. And there are very few types of treatment which will do that. You can expand, that will always take it forward a little, but you really need to change the posture of the patient. And I only know of one treatment which does that.
Absolutely.
The rest of you must have a point of view on this. It's an interesting aspect.
I do use, when I was in practice, used to use quite a lot of reverse pull headgear to pull the maxilla forward and up. And I found that worked extremely well. For example, let me just show you. Yeah. Can I show you? That lady was 35 or 37 years of age.
Yes.
And she's had she was class 3 with a reverse overjet. And the whole maxilla came forward over 6 millimeters. But I like to make it clear she had a lot of craniosacral work, which released all the restrictions in the body and the sutures in the head.
Yes.
Also,
I'm
this is
sure
happening.
osteopathy can help, certainly with bald pull headgear. But I think the easiest way is to expand the maxilla. It's so simple to do and much less troubling for the patient than bald pull headgear. But yes, bald pull headgear is always an option. No other comments?
And also, this has also happened when during the fixed treatment, the orthodontist recommended intermaxillary elastics. For class 2, for example, if they are wearing the elastics, it seems to correct the class 2. And in the end, they realize that the mandible is still back. So wearing the elastic is not a solution.
No, and inter-arch elastics always pull the maxilla back.
Okay, introduce Dietmar.
Yes, perhaps we could ask you, Dietmar, if you are ready now, and it would be nice to hear your viewpoint.
John, can you hear me? Hello, John. Can you hear me? Hello? Can you hear me? Hello, John, can you hear me?
Hear you, yes.
I can't hear any of you.
Keep going.
Okay, you can hear me now. John? Yes, I can't share because I wasn't listening. I've just received some visitors, but I'm ready for my presentation. Hi, guys. I've lost you again.
We can see your slides. We're ready for you to present. Everyone's waiting for you to start.
Wonderful. I'll just go to my screen. I just need to know, there we go. And man, it was working perfectly. Okay, let me try this again. There we go. I don't know why I'm having such. I'm going to presentation mode. Can you guys see and hear now?
Yes, that's great.
Wonderful, thank you. At last. My interest in the whole issue of orthopedics and retraction is born out of the fact that during 30 years of being in practice, I encountered problems for which there appeared to be no apparent answers. Why is there orthodontic relapse? Why toothache when there's no pathology defects? Why do dental reconstructions fail despite meticulous planning and treatment? And why are crowns high after being placed? My interest arose in 2007 when I attended a lecture by John Flutter from Brisbane in Australia. And he spoke about form, function, and posture in human development. And since then, I have worked with colleagues such as Skip Truitt, Terry Sparl, Ian Walters, Francois Rousseau, Tony Ansell, Chris Farrell, Roger Price, Dave Singh, and I had the pleasure of hosting John at my home and in my town several years ago. And that's when I was exposed to orthotropics. I haven't used the orthotropic appliances simply because I haven't had the opportunity to train in them, but I have used other appliances which I've been using in combination with ALF appliances and with fixed appliances. There's a certain protocol I follow, and my interest is the airways to a large extent. And the whole issue of why I got into this is because of reading van der Klaar, who said if there develops any regional van der Klaar, and then reading facial growth by Hans and Enloe, and they said if there develops any regional childhood variation along the course of the airway that significantly alters its configuration or size, growth then proceeds along a different course, leading to a variation in overall facial assembly that may exceed the bounds of normal pattern. The airway functions in a real sense as a keystone for the face. What were they saying? Mouth breathing results in altergenic signals from the functional matrix, and the genic tissues then work toward a different balance combination, producing a variation in facial morphology. In other words, mouth breathing, which constitutes this functional breathing, results in the development of or aggravates jaw imbalances, cranial distortions, establishes malocclusions, and negatively affects the normal growth and development of children, and affects the systemic health and well-being of adults. And herein lies the implication for us as dentists. The oral jaw musculature is responsible for the pivotal, vital positional relationships that maintain the oropharyngeal airway. The axial musculature around the vertebrae is also involved. These primitive neonatal protective mechanisms provide the motor background upon which, with growth, all the postural mechanisms of the head and neck region are developed. Physiological maintenance of the airway is of vital, continuing importance from the first day throughout life. That comes from Hans and Enloe. Just reading from Peretz and Levy, Restless Nights, Understanding Snoring and Sleep Apnea. What I liked there was the following passage from the Bible, Genesis 2 verse 7. Then the Lord God formed man of the dust of the ground and breathed into his nostrils the breath of life, and man became a living soul. Why nostrils and not the mouth? Some other books you could read, and you can see there's this intimate relationship between obviously the oral region, the nasal structure, the airways, the tongue, and there's an intimate relationship between the soft tissue matrix and what happens with bone development. I'm going to just escape from this one, and I'm just going to change to the next presentation. This is a presentation that I gave again way back in 2011 at a conference. At that stage, I called it functional jaw orthopedics, and does it really work? I got this again, just the whole functional matrix concept by van der Klaar, bone growth. 50 years of research by Enloe and Hans unequivocally showed that bone growth occurs as a result of remodeling, displacement, and area relocation, and not due to periosteal deposition and the end osteal resorption, as has been and still is erroneously taught today. The maxilla develops from ectoderm, called dermal bone, and is much more influenced by environmental factors such as dysfunctional breathing, e.g. mouth breathing instead of nasal breathing, object habits such as finger sucking and dummies or tongue thrusting. Mouth breathers will typically have narrow, high vaulted palates, long faces, and receding jaws. The maxillas of 80% of children born today are either narrow, short setback, or a combination of all three. The human face and skull have shown more change in the past 300 years compared to the previous known history of mankind. The mandible develops mostly from embryonic mesoderm, called chondral bone, growth of which is guided by our genetically encrypted recipe. The mandible is a complex sandwich of both chondral bone, which is that's the body, which is genetically controlled, and dermal bone, the alveolar ridge, which is influenced by environmental factors. Why early intervention? Virtually everything once presumed to be reasons why clinicians must work with growth were obsolete perceptions that existed before there was a working understanding of craniofacial development. Thus, orthodontics as a clinical discipline is markedly out of date. I do not see a groundswell of interest throughout orthodontics that we should do what badly needs to be done. This greatly saddens me, and I do not understand. And this was said by Hans and Endler in the Essentials of Facial Growth. Beginning orthodontic treatment early seems eminently logic because it enables the complete or partial correction of many incipient discrepancies, or at least a reduction in their capacity to grow worse. Interception or early intervention employs simple therapeutic techniques that do not overtax the limited stores of cooperation of young patients can bring to the therapeutic encounter. Its objective is eliminating or minimizing dentoalveolar and skeletal disorders that interfere with growth, function, aesthetics, and physiological well-being. This comes from Patty and Perrier de Arc, Clinical Success in Orthodontics. Orthodontic treatment should be in harmony with modern medical thought. It is better to prevent than cure. We should not treat the symptom, we should treat the cause. The therapeutic devices available for this endeavor are not complex, but deciding which ones to use and when to employ them is far from simple. The therapeutic choice is nothing more than the last act in a complete diagnostic process. The ideal age for an initial orthodontic visit in the author's view is when the patient is 5 or 6 years old. Clinical Success in Early Orthodontic Treatment, Patty and Perrier de Arc. These are just cases you can see done way back in 2009 when I was just starting to get into things. You can see this is where I started with this patient, 29th of the 1st, and by the 13th to the 12th, 2010, that's where we were. Again, you can see the profile, 29th of the 1st, 13th of the 12th. That's the intraoral view just from the front. They're just side views. This is the Ceph taken at the start, and when we, as I got to a certain point in treatment, you can see the pan, the top one at the start, the bottom one as we were progressing with treatment. This is another case, 5th of the 3rd, 2009. Just to illustrate, 5th of the 3rd, by the 12th of the 10th, 2010, we were there. Not a very cooperative patient, but we did make progress. You can see how we went from that very closed vertical bite to a more acceptable vertical anterior dimension. Again, her Cephs at the start and at the point where we got to in 2010. That was a starting pan. That was the pan in 2010. My biggest challenge has always been the upper canines. Nowadays, I am fortunate enough to be able to work with 3D CBCT, and I always check those upper canines. And my treatment is also very much guided to a large extent by the position of those canines. This is another patient. Unfortunately, this is a patient where the treatment didn't go all that well. You can see the situation, and what happened ultimately was that upper canine got stuck, that one came down. Even though we did get significant development. Another patient, 2009, that's where we started off, and that's where I got to by the 3rd of the 8th, 2009. You can see in her case the canines were busy coming through. This is another patient. He came to me. He hadn't been at school for 2 years. He had no friends. He couldn't breathe. He literally breathed like that when he came in through the surgery door, and his mother was desperate. They'd been to every pediatrician, medical doctor, specialist physician that they could find in the country, and eventually one of them was truthful enough to tell them that there was nothing that they could do for him. So she brought him to me. That was the 8th of the 12th, 2008. That's what you can see. His maxilla is completely deficient, developing a class 3. That's the occlusal view, the occlusal view of the lower arch, and this is where we got him to by the 19th of the 6th, 2009. He was a completely different boy. And as you can see, there's still crusting around the nose, but he eventually grew. Growth was stunted. He eventually grew into an 18-year-old who was 6'5". I believe if he hadn't had treatment, he would have had stunted growth. So you can see there the development we achieved, and this is a 3rd of the 4th, 2010. Two completely different boys. One canine's popped through, the other one's busy coming through there. As you can see there, as you can see there, this is another patient, and you can see the development from the 18th of the 5th, 2008 to the 3rd of the 4th, 2010. You can see difference in, obviously, the arches, maxillary arches, from there to there, there to there. Not a very cooperative patient, but we did make progress with it. Those are the appliances that I used to use. I now tend to work mainly with ALF, simply because I haven't had the opportunity to train in orthotropics yet, which I'm hoping at the age of 63 I will still have time to do. Another patient, bilateral skeletal crossbite, treated him not cooperative at all, and that's where we got him to. We started treatment 19th of 10th, 2009, and that's where he was 27th of the 1st, 2011. So we were getting there, and ultimately we did get there. Another patient, 18th of the 3rd, 2009, so we started with him, and that's where we got to by 2nd of 11th, 2010. So we put him in a situation where we had something to work with. You can see no place for his canines. We brought his canines down ultimately. Another patient, you can see that recessive mandible, and we developed her art, and we ultimately got her to this situation where at least everything was busy erupting. We got the maxilla forward, mandible forward, and it gave us a situation that we could work with. This is a very special patient to me, a young man who was mentally compromised, and he was actually getting married to a young lady also in a similar situation, and he just wasn't happy with his smile. That's where we started off with him, and I had to get him ready within literally 11 months, 18th of the 9th, 2009, for his wedding. And this is 3rd of the 1st, 2011, and we can see that there was a great improvement, and he was happy. He was happy to be there. So as development is it important for us to stop retractive orthodontics? Yes, it is. There's no question about that. And it's a work in progress. I've been doing this for years, and I continue refining my processes, and my biggest wish now is to use orthotropics as a treatment protocol. Well, thank you for your attention, and I hope that you could hear that.
Yes.
There we go. All done.
Thank you. Well done. We now have a question. Shall I read it? Classical orthodontics straightens the curve of Spey. We're being technical now. That is the level of the lower jaw. And so I think also leads to vertical growth. Is it not necessary to restore the Spey curve the straight mouth technique is wrong. This is an opinion, obviously, of a dentist who has drawn attention to the fact that orthodontic treatment, by and large, levels the arches when there should be a gentle curve in the lower arch, which I agree with. Is anyone there interested in making a comment on this? I could do so myself, but I would rather one of you did. Dominique, if you're an orthodontist, would you feel that you would like to say something on this?
My experience is that it's very difficult to strike the curve of SPI with braces. So after years now, I can tell that with BioBlock it's much more easier to find the curve of SPI.
Yes, I agree with you there, Dominique, because BioBlock holds on to the premolars or the deciduous molars and pushes down both on the anterior teeth and the posterior teeth. And that automatically reduces the curve of space, and you can adjust the curve of space to what you think it should be. And I agree with the person who asked the question. There should be a slight curve of space. It shouldn't be too deep, or you'll have a deep bite, and it shouldn't be too shallow, or the mechanics of the jaw movements don't really work. Someone else?
Yeah. John, I would question what nature does. Where do we have a curve of speed? I'd ask you that.
Are you asking me why we have a curve of space? If
Yes.
you want to articulate the teeth using the TMJ joints, you'll find they only really do that well if you have a gentle curve of space and also a gentle curve of montum. In fact, I think they developed themselves as a result of the movement of that very complicated joint, the TMJ, which could go forwards and backwards and sideways as well as open.
Okay, so can I start? Yes? So the next topic, forward growth and its benefits. As I said before, I started to visit John and Mike at Pearl Clinic, and this is the picture just before the entrance of John's clinic. And one of the main reasons was this situation with my 5-6 years old son, and the snoring and episodes of sleep apnea. Me and my wife, we were hearing this every night, so it worried us a lot. Especially that moment. And at that time, I knew that there is no solution for him using the classical orthodontic treatment. And his occlusion, my son's occlusion at age 5 was like that, so not bad, but the deep bite is obvious here. And his face at 6.5 years has a sign of vertical growth. Now I see this, it's obvious too for me. And at the age of 6, from orthodontic point of view, the occlusion of my son was quite well. But the John's measurements shows us, measurements show that his, it's not everything okay. So especially his body posture and the signs of there are the signs of vertical growth, and From that point, I started to treat him with a classical orthodontic approach. Of course, I made a X-ray, and as you can see, there is lack of second left incisors, lateral incisors. But it's not a problem for orthodontists. Okay, I opened the bite and started the training phase. So after 7 months of treatment, I made another X-ray, and you can compare how his airways changed that time. So how it was lifted up. So you can see how his upper and lower jaw move forward after 7 months of treatment. And today my son is almost 10 years old. His body posture is much more better than before treatment, and his face looks much more better than before. His occlusion is still open, but he's still in the treatment. If you compare with the Bolton profile, today his profile is very, very good. We are waiting for the forward growth of the chin. I think that it will happen in the future. Okay, and here you can compare his profile at age 5, 7, and today. So I think that it's quite good. And what is the most important for me and for my wife is his breathing during the sleep. So he's sleeping like that, with closed mouth, sealed lips and teeth together. I examine his teeth. You can see how I push a little bit and check jaw and teeth are together. Of course, he's in the bioblock 3 is in his mouth. This is the last picture of his sleep. So now he's sleeping and breathing with complete silence. But the biggest test is the sleeping in the sit position. So in spite of this position, he has his lips together and teeth together. So I think that everything is okay and moved in good direction. So thank you, John. We are trying to develop orthodontics in Poland. I think that it will be the future of orthodontics. Thank you very much.
We've got a question coming up.
That was a really good result.
Very good result.
Oh, thank you very much.
Really good result. You must be very pleased.
I'll read out the question. Does chewing gum work? Does anyone want to say something on that?
It's used
Right.
correctly. No. I think it can be very beneficial as a training tool if you want to get the tongue up into the palate. So yes, it can work, I think, but not between the teeth so much, but up into the palate and squished by the tongue. So it could be a tongue training system.
Anyone else want to make a comment?
Absolutely, John. I agree with Granville. The other thing about bubblegum is it's a case of when is it being chewed. Bubblegum doesn't have a very good on the temporomandibular joint, and also you can have muscle hypertrophy. So I think bubblegum is good as Randall says, as a training process, but to be a chronic bubblegum chewer also isn't a good thing.
May I say a word on chewing gum? My personal opinion is if we look back at ancient man, he used to live on very low calorie food, with the result that he had to eat literally pounds of food a day in order to be able to simply support his calorie intake. This meant chewing huge amounts of, I don't know, grass, leaves, twigs, whatever, to get any nutriments out of it. Therefore, he was grinding his teeth together most of the day. And as you know, their teeth used to wear the cusps flat within 2.5 years of eruption. That's a very short period, considering most of you in the room now have no wear on your cusps at all. So we should chew a lot more. The problem is that no one yet has produced a very hard chewing gum. I have written to many chewing gum manufacturers, and they write back to me and say, well, everybody these days likes to have soft chewing gum. And I say that they need hard chewing gum, but the manufacturers are not moved by this. They just want to sell their gum. Right. I think it's probably now time for me to do my own presentation. I will show what this first slide, because it illustrates very much my feeling about retractive orthodontics and why I organized today to really try and prevent retractive orthodontics anywhere in the world. This was a pretty young girl. She was actually the daughter of a doctor, and he went to the orthodontist because she had a slight overjet. It was only about 3 or 4 millimeters overjet. The orthodontist said, yes, we can cure that easily, but we'll need to extract the premolars. And so my doctor friend said, well, surely we can do it without extractions. So the orthodontist said, yes, all right, I'll try and do it without extractions. He treated her for 2 whole years with headgear and still hadn't reduced the overjet. In other words, she had slightly sticking out teeth. He pulled them back, but in fact, as he was pulling back, her lower jaw was opening downwards and backwards, so that the overjet, the difference between the upper front teeth and the lower front teeth, never reduced. All that happened was her face went further down and back. And you can see from the result that it has totally ruined her appearance. And she's an attractive girl. But think what she could have been if she had maintained that original forward growth. I remember at the first interview, her mother came to me in tears. Her father, as I say, was a doctor. And in the end, this orthodontist said, well, I can't reduce the overjet with headgear. We'll have to take out her premolars. Well, my doctor friend said, surely not. But the orthodontist, well, there is no other way it could be done. So he extracted the premolars and continued with the headgear. But all that happened was that her face went further down and back. And so she had a very long retruded face, minus 4 premolars. I don't know if there is room for her wisdom teeth, but it wouldn't surprise me to know that there is not. He actually was so upset that he hadn't been warned that this could happen, that he complained to the General Dental Council, who are the authority in England, and have the right to control people, and particularly stop orthodontists doing damage. But when the General Dental Council saw the patient, they said, well, faces are often pulled back like that. That is a very common result from orthodontics. Therefore, we don't think you have any grounds for complaint. This is normal orthodontics. And I think they were probably right. It is normal orthodontics, but it can do a huge amount of harm to some patients. Perhaps you can see the next slide, William. Now, this is interesting in that this boy called Brown, his picture, the one on the left, was circulated to every single orthodontist in Britain. Should I say everyone who was listed on the orthodontic list. And they were all asked to say, how do you think he should be treated? His upper teeth stuck out 10 millimeters, I think it was, from the lower teeth. 91% of the orthodontists in England said, well, the right thing to do is to pull back the front teeth because they stick out. And that is the general attitude of orthodontics. If the front teeth stick out, pull them back. And this is typical of retractive orthodontics that I really think should not be done anywhere. You can see that the consequence, because he was actually treated by extracting a premolar on each side and pulling back his front teeth. Now his teeth are beautifully straight and they meet perfectly. But look what has happened to his face. Imagine what would have happened if his lower jaw had been taken forward instead. That would have produced a much better looking face. Now, the research shows that people like to have a good looking face far more than they feel they need straight teeth. Most people have their teeth straightened so that they can look better. But the reality is, if you have a nice looking face, your teeth will be straight anyway. If you have an unattractive face, your teeth are very likely to be crooked, but straightening them won't alter the attractiveness of the face. Now, the ultimate answer here, I think, is that he should have been taken forward. And I think that young children these days are far more interested in the facial appearance. In fact, research shows that teenagers mind more about what they look like than almost anything else in their life. Far more than their parents, their children, their friends, their work. They really mind how they look. When we get older, we get used to what we look like and accept it. I got a long face and I know I should have a square face, but I got used to it. And most people as adults don't mind so much about the face, but we shouldn't forget that teenagers really mind, and that the shape of the face has a huge impact on their future. It determines their success in life, their income in life, and much more subtle things like it actually does determine their intelligence. Attractive people are more intelligent, probably because they get better teaching. But unattractive people are very likely to be unhappy and depressed, and the high levels of suicide. Unattractive people are far more likely to commit crimes and be antisocial and to be unconventional in many other ways. So it is a huge advantage to have your face taken forward rather than taken back. Now, I'll continue with my next slide. This is really an example of just what I've been talking about. These are two identical twins. You can see them on the left. I have treated quite a few twins in my life. And in this instance, as I have on several other, I invited an orthodontist to treat the twin above. And I said I would treat the twin below. I actually said to him, which twin would you rather treat? And he chose the top one. In fact, I can see why he did not have such a severe malocclusion. Now, he said that he could correct it with fixed appliances and that he deliberately would not pull back the upper incisors. Well, he tried not to, but I have no doubt, in fact, the x-rays show that, in fact, he did pull back the upper incisors. Immediately, you put on fixed braces, which is what most orthodontics do, or Invisalign, if you wish to use that, they all retract the upper front teeth. And retractive orthodontics is bad for the face. Look at the change that poor lad suffered. Now, the twin below, I treated the usual way I do. I enlarged his maxilla. I then taught him to hold his jaw forward, and that caused it to grow forward, as you can see there. That is the difference between retractive orthodontics and, I suppose I could say, protractive orthodontics. But as you can see, with identical twins, you can make a huge difference between the two alternatives with growth. I'm sure you can all understand why I'm so against retractive orthodontics. And I think we can look at this last slide. This was just a patient I treated. But look at the little boy on the left. Try and think of what his success in life would be, how he would have achieved team leadership, or a really top-level job, or married a very beautiful girl. I think we would all agree that his chances would have been tough, prejudice, you might say. But we simply enlarged his upper jaw so that it would grow forward, as we did there. We then encouraged his lower jaw to grow forward, and we now have a face that looks like that. Now, how do you judge that boy's success in life? Very differently. He looks as though he could easily be quite a dominant and leading personality. And that influences the whole of his life chances of becoming a success in life. Whereas if you retract upper front teeth in a young child, say, of 10, 12, even 14, you will severely damage his social chances of being a successful liver, one might say. Certainly reduces the chances of being a leader. I think that is really why I wanted to set this weekend up. And it is my very simple message: don't ever retract teeth. And sticking out front teeth should not be pulled back. We no doubt will have some more questions, and we'll be coming up for completion in another 5 minutes or so. Are there any questions, William?
We're just looking for a couple.
No, John, just was to say that was a very, very interesting presentation as always. Your work is phenomenal.
Thank you very much. They're just people. Here is another question. I'm deeply upset that most of the orthodontists believe that their poor and extremely invasive treatment is the only solution, and they have no responsibility for ruining kids, people, faces, and lives. Well, that again is not really a question, but I think most of us might agree with it. Right. Orthodontics said the only way to fix my overjet is to extract a bunch of teeth and bring my face back and get jaw surgery. Well, I don't know what age the young man is, but I'm quite sure that that is a better solution. What do any of you feel?
There is a better solution at any age, for sure.
I
So
would agree.
extraction, it has to be very well analyzed and avoid as much as possible. Even with some teeth, extraction is not something that I recommend, except it's something that it's really damaging the second molar, or just in few cases. Otherwise, even wisdom teeth has his role in the mouth and has to be there.
What will he do? Will he be able to find someone who will take his jaw forward? Any of you?
Will you be able to find me?
It's just to maintain a good oral posture. It's your teeth together. In the comments, I saw the wrong comment that what is mewing. Mewing is teeth together. Not, you don't have to have a slight gap between your upper and lower teeth. Your teeth should be together. Don't push it, but they should slightly touch, like a butterfly sitting on your palm, just touching.
So the tropic premise, don't forget about the tropic premise. That's the key.
Anyone else like a last word? Yes, brother.
Right. I have to have a question here with you, John. What actually holds your mandible forward in your adult cases? Because I can get a mandible forward and to stay there because you get remodeling in the dental fossa, the socket, and you get slippage of the temporal bones, but you don't get growth of the mandible, though it could change shape slightly. We're talking about adults. John, what holds your mandible in the forward position? Is it the muscles, or do you get skeletal change?
That is a very interesting question, Premolar, and I regret that I've been lecturing now for over 40 years, and only a handful of people understand how to make the mandible grow. I found out by accident, because I was working out the tropic premise that you need the tongue and the palate, the lips together, and the mouth closed. And the difficult thing is to keep the mouth closed, because how do you keep it closed at night? So as you know, I developed this stage 3 appliance, which forces children to keep their mouth shut all night. Well, if you keep your mouth shut all night, that gets into your subconscious mind, so that you subconsciously keep your mouth shut all day as well. And anybody, and I found out this quite by accident, that anybody who keeps their mouth shut all their life, the jaws will grow forward. Not just the mandible, the maxilla as well. It's just natural growth. But of course, because so many people leave their mouths open, it doesn't happen. In fact, naturally, I think it happens in less than 5% of the population. But the way to cure it is to fit an appliance which will force the child to keep their mouth shut all night. And as I say, I told people that for 40 years, but there is still only a handful of people in the world who actually do it. I think the others find it too difficult, and it is not easy. Any more questions?
Not to respond.
No, we're coming up to final time. Would you like to say a last word, Dietmar? Any final words?
Yes, absolutely. Thank you, John. Thank you. It's been a real pleasure. And I just want to say that I believe that you have changed the world of dentistry, and that the tropic premise holds true. The one big thing that I think is important that folk need to also be aware of is the importance of nasal breathing. Um, I think a lot of folk don't realize how important that is, and also the fact that I've always been concerned about the concept of what is a big airway. Everybody talks about bringing the face forward, bringing the tongue forward, bringing the mandible forward, the tongue against the roof of the palate, teeth together, to increase the volume of the airway. But in my experience, increasing the volume of the airway doesn't always translate into better breathing. And I've always questioned the concept of better breathing. So I think we must view this from the point of view that facial development obviously is also important. Tooth development is important. And the airways are important, but we need to look at it from the perspective of efficient breathing, both from a structural point of view and a chemistry point of view.
Right. A final word, Dominique?
Final word is start the treatment early. So interceptive treatment is the best solution, and the main goal is our airways, not teeth. So concentrate on airways and general health of children.
Right. India, would you like another word?
Yes, I would like to say for the audience, there are a lot of questions about what to do, and so we cannot give a consultation for all of you. But you just have to seek for the truth. Ask your doctors what is going with you, what are they going to do with you, and seek for the second, third, and 10th and 20th opinion. Just seek for the truth, and you'll find it.
Thank you. Ella, do you want to say a final word?
Yeah.
This idea of debate is very, very important. It's a very important subject. But the main problem for me is the education system. It's not enough for just a small group of people in the world talking about facial growth guidance, about expansion. If all university in the world are not changing their program, they have to teach a different program in the school, in a residency university. The lack of correct education is the most important problem. So if you want to really help the people, I think we have to do something to change the educational system. And this is very hard. This is so difficult because it's like in a politics. For patients and for parents, it's so difficult to choose between so many therapies. There are so many appliances. There are so many techniques. The people are talking about techniques. They don't treat a whole person. They are not treating a person. They are just using some new brackets, new high-tech wire, digital, and they are not putting the right diagnosis. They have to be very careful about getting a correct diagnostic and a correct treatment plan. And they have to ask for second opinion, many, even 10 second opinion, until they will be at least convinced that they are doing right for the kids and for themselves. And it's difficult.
But I will have a final word then. I will get to address the point that Randall made, but all of you mentioned the question of airway. If you keep your tongue on your palate, your airway will remain open. And that is why it's so important to train people to correct their subconscious posture. If their tongue is on their palate all night, even if the jaws are a long way back, the airway itself will still remain open. You'll find it is the tongue falling away from the palate, which is the cause of nearly all sleep apnea. Anyway, finally, I will say thanks to all of you. We must stop retractive orthodontics, and let's hope this meeting will help. Goodbye.
Thank you, John.